Hello everybody, this is Carlos from Army of Nurses and welcome to another quick video. In today's topic, we are going to be covering the topic about hypertension. It's also called high blood pressure in layman's term, and it's a very common condition that we might experience in hospital. So, blood pressure is just the force exerted by the heart on the arteries to keep perfusion going so that you can perfuse your vital organs. So your heart, it has to contract and overcome the pressure that is already inside your arteries in order to be able to perfuse and send the blood to your vital organs, your brain, your lungs, your kidneys, your liver. And depending on how much force it must overcome, then that's the blood pressure. There's many different factors that affect the blood pressure. Your mean arterial pressure, also denoted here as MAP, is your cardiac output times the systemic vascular resistance, as we can see here. Cardiac output is heart rate, so how fast your heart is beating per minute, times the stroke volume. And the stroke volume is just how much blood is pumped out from the ventricle with each heartbeat. Systemic vascular resistance, on the other hand, is how much resistance there is inside the arteries that the heart must overcome. One of the biggest determinants of systemic vascular resistance is the diameter of the vessels. So in this analogy, if we have a vessel that is quite wide, then there isn't much pressure inside. So in order for the heart to pump blood through this vessel over here, it would be easier because there isn't as much pressure to overcome. However, if there is an artery that is smaller, like this one over here, the pressure will be higher because the heart needs to be able to squeeze all that blood, the same amount of blood that is going through the first artery, into something that is much more narrower. So in that case, the heart needs to work extra hard just to be able to push the same amount of blood, and that will lead to an increase in your blood pressure. The narrowing of the arteries could be due to vasoconstriction, could be due to cholesterol or plaque buildup, could be an obstruction of some sort. So there's multiple reasons why the diameter of a vessel might be narrow. Our bodies have multiple receptors in the cardiovascular system that allows us to control and mediate, a normal blood pressure. Alpha receptors. These receptors are located in the smooth muscles, and once they are activated, their job is to cause vasoconstriction. So beta receptors, there's two types. There's beta 1 and there's the beta 2s. Beta 1 receptors are located in the heart, and they have multiple functions. Once they are activated, they can be positive chronotropic. That means that it increases the heart rate. They could be positive inotropic, which means that they increase the contraction, and they could be positive dromotropic, which means that they increase the conduction speed of electrical signals through the heart. So beta 1s, originate from the heart. Positive chronotropic effect, increase heart rate. Positive inotropic effect, they increase contraction and contractility. And positive dromotropic effect, they increase the conduction of electricity through the electrical system in the myocardium. Now, beta 2 receptors are located in smooth muscles, but also it's located in the lungs. And once they're activated, their job is to cause dilation. So how can we remember beta 1 and beta 2? Well, we can say beta 1, we have one heart, and beta 2, we have two lungs. Excuse me. The last type of receptors are called the dopaminergic receptors. The dopaminergic receptors. These receptors are located primarily in the renal and mesenteric arteries, and their job is to cause vasodilation when they are activated. As you can see, there's many receptors in the body, and they all play a crucial role in order to be able to maintain a normal blood pressure when they're activated and they're deactivated. Blood pressure, it's actually divided into systolic and diastolic. Systolic is the force that when the heart contracts, and that's the amount of pressure that the heart is exerting on top of the pressure that's already inside the vessels. Once the heart goes into diastole, when it relaxes, there's still pressure inside the blood, because the blood that's already inside the arteries, they exert a pressure on the walls, and that's the diastolic pressure. And it's usually written as a fraction. So normal blood pressure would be anything less than 120 systolic and less than 80 diastolic. So anywhere between, for example, a blood pressure of 118, 116 over let's say 78, 76 is actually perfect blood pressure. Prehypertension, it's a stage in high blood pressure that a lot of young adults have. This is a stage, that is completely asymptomatic, because pressure is still within quite a relative normal range, but it's slowly going to creep up. So in the prehypertension stage, the blood pressure, is usually anywhere between 120 to 139 systolic, and diastolic goes between 80 to 89. Hypertension stage 1, in this stage, still some people might not be able to feel clinical symptoms of hypertension. But their blood pressure, if you do a measuring of their blood pressure, systolic would fall anywhere between 140 to 159 systolic and 90 to 99 diastolic. Hypertension stage 2, in this stage here, you might be able to encounter patients who do complain of clinical presentations associated with the hypertension, such as headache, vision, chest pain, palpitations. And in this stage, usually the blood pressure is greater than 160 systolic and greater than 100 diastolic. In a hypertension stage 2, it's highly recommended that patients do seek out medical help. And if you do encounter a patient in your practice that does have a blood pressure this high, the patient might require immediate intervention, as it's fitted by how the patient presents clinically. So a lot of monitoring will be in place. The next would be there's two types of hypertension. There's primary hypertension, also called essential, or idiopathic. And this type of hypertension actually occurs in quite a high percentage of patients that present with high blood pressure. It's anywhere from 90 to 95%. And it's called idiopathic because there is no precise known underlying reason that could be causing the blood pressure to go that high. So some of the risk factors could be age. As we age, our arteries, they lose their elasticity, they lose the recoiling ability that they have, and they become stiffer. So once they're stiffer, then the heart needs to work harder in order to push blood through those already hardened arteries. Gender, males usually have a higher blood pressure than females. It could be by race and family history. Secondary hypertension actually occurs in about 5% to 10% of cases. And in the secondary hypertension, we have known causes. We know what's causing the increase in blood pressure. This could be anywhere due to malignancies, renal or kidney problems, heart problems, endocrine problems, imbalances in hormones, thyroid problems. It could be neurologically related. High blood pressure could be because of a tumor, could be because of a mass, and pregnancy as well. Which can lead to preeclampsia. So some of the complications that and symptoms that we might experience people who have high blood pressure, kidneys, it can cause actually kidney injury. And patients might complain that they are, or they present with hematuria, which is blood in the urine. When we do urinalysis, we might find proteins in their urine, and whenever there's protein and blood in the urine, it's a pretty good indication there is some kidney damage inside, because as the glomerulus and the starts to filter all the blood, for the electrolytes and all the stuff, it doesn't allow protein and red blood cells to pass through because they are too big for the glomerulus filter. However, the fact that when we do find protein and blood in the urine, that means that they were able to escape that very fine filter, which leads us to know that there must have been some kind of damage to the filter, in this case the glomerulus, right? Eyes, they usually can present with a blur vision, flashes. They might come with like diplopia, where they're starting to see double, and they can actually read the biggest thing is it actually can it can lead to retinal damage. So, and retinal damage is very serious in the sense that it can actually lead to blindness. High blood pressure affects the brain as well in the way that it can cause strokes. It can cause dizziness and headaches. On the cardiovascular side, it can actually cause heart attack or MIs, myocardial infarctions. It can cause palpitations, chest pain is the most common sign that they might be presenting with. They can cause bleeding or hemorrhage, or they also can present with aneurysm. So once the pressure has been high for so long, then there are certain parts of the arteries that become weaker, and once they become weaker, they can actually become a balloon. And this balloon over here is very weak compared, the walls over here are very thin compared to the rest of the arteries, and it gives them a very high risk of bursting or breaking off, and that can become life-threatening at any moment. So some of the pharmacological treatments for high blood pressure include the ACE inhibitors. We have the ARBs, or the angiotensin receptor blockers. There's also beta blockers. And on the other page here, we have diuretics, excuse me, calcium channel blockers, and there's other miscellaneous medications. So we're gonna start with the ACE inhibitors. And ACE inhibitors, they are all your medications that, the generic name ends up with pril, so there is for example, ramipril, right? And what ACE inhibitors do is they prevent angiotensin 1, I'm going to call this angio 1, to becoming angiotensin 2, and I'm going to call it angio 2. So for angio 1 to become angio 2, there must be an enzyme. The enzyme, we call it ACE, and ACE is what converts angiotensin 1 to angiotensin 2. So angiotensin 2 is a very potent vasoconstrictor, and once angiotensin 2 is activated, the aldosterone system is also reactivated so that more water gets reabsorbed by the kidneys, and that increases blood pressure. So what the inhibitors do is they inhibit the ACE enzyme, so the angiotensin 1 cannot be converted to angiotensin 2, and it can prevent the whole cascade of vasoconstriction and aldosterone release, right? So it blocks, and ACE inhibitors, they block the vasoconstriction caused by angio 2, and since angio 2 is blocked, they will prevent the aldosterone system from activating and reabsorb more water, and that was something that will lead to a higher blood pressure. One of the things with ACE inhibitors, it causes a cough. That's a very common side effect, and the reason is because the angiotensin converting enzyme, or ACE, this enzyme here is actually produced in the lungs. So once you have something that blocks something that is produced in the lungs, there's a higher chance that we might get a symptom that is related to the organ where it was originated from, in this case, a cough. The second type of drugs that we use in practice are also called the angiotensin receptor blockers. They're called ARBs in short form, and these medications are the ones, the generic names are the ones that end with sartan. And an example be irbesartan. These medications here, they do not have the cough that the ACE inhibitors have, because how they do is, even though angiotensin 2 has been created, it must bind to the receptor in the smooth muscles, right? So this is the receptor. So once angio 2, I'm going to put angio 2 here. Once angio 2 is able to bind to here, then that's what causes the whole cascade of vasoconstriction and aldosterone release. But if we have a medication that is able to block this part here, let's see, block this part here, then angio 2 will not be able to bind to the receptor, right? And it will not be able to produce the effects that they have. So this one here is your ARBs. That's how they work. They just block the receptors. That's all they do. The third type of drugs that we use are called beta blockers, and the beta blockers, they are the ones that end up with LOL. Excuse me. And an example would be your atenolol or your labetalol. Right, so there's a lot of different medications out there. They usually end with LOL, but that's not an absolute rule. But it's an easy way to remember them. Beta blockers, they cause a negative inotropic effect If you remember from a few slides earlier, inotropics are force of contraction, and they also have a negative chronotropic effect. And chronotropic was the heart rate. So once beta blockers work in the smooth muscles, they decrease blood pressure because they decrease the contractility, of the heart, and they also decrease the heart rate of the myocardium that is pumping, so that it uses less energy and it works so that it doesn't work as hard, and that's particularly useful for patients who have weakened hearts or might have a heart attack. Another type of drugs that we use are called the diuretics, or how patients normally like to call it the pee pill, medication that help them pee. The most common ones that nursing students are able to encounter would be hydrochlorothiazide. It's actually shortened as a HCTZ, Lasix, or furosemide, like the other name. These two medications here, we need to be careful with the potassium level, because since they are loop diuretics, they affect the loop of Henle in the kidneys. They prevent the reabsorption of some of the electrolytes, so potassium is lost quicker in these cases. So we'll have to make sure that patients don't become hypokalemic while on diuretic treatment, especially with Lasix. Another common one that we use is called metolazone, and this goes by the name of ceroxylin as well. So this medication is also a diuretic, but it tends to affect more sodium. So it's used for patients who have hypernatremic states that they need to be, and that they are bloated. So it helps get rid of the water and also helps get rid of the salt. Another few that we use in practice is called spironolactone, and there is also amiloride. So both of these medications, spironolactone and amiloride, they actually spare potassium loss. So these medications here, they are useful for patients that need to be diuresed, but that their potassium is too low. Now, in the other hand, we gotta make sure that if the patient is hyperkalemic, if their potassium is a little bit on the higher side, that we have to reconsider these medications, because it might cause their potassium to go higher once they lose water and they become more hemoconcentrated. Calcium channel blockers, these medications block calcium channels, which prevent the signaling and the stimulation of muscle contractions in the smooth muscles, and they come in two flavors. So there's calcium channel blockers that have no effect on heart rate, and there are those that have effect on heart rate. So calcium channel blockers that have no effect on heart rate, they're purely to decrease your blood pressure, and these ones, for example, include amlodipine, also called Norvasc, and there's also nifedipine. So, and calcium channel blockers that do have an effect on heart rate are examples. They can be used to control a fast heart rate, and also when they are a little bit too hypertensive at the same time. So it's like a good combo. If they are tachycardic and hypertensive, physicians or healthcare team members might be able to consider this medication as an option. So some calcium channel blockers that do have a heart rate reducing effect, it's verapamil and diltiazem. Other medications that have also they're also used to decrease blood pressure. Common ones include clonidine and terazosin. And these two tend to work more on the alpha receptors. So remember that when alpha receptors are stimulated, they cause constriction. So these medications, they either block the alpha receptors or prevent epinephrine and norepinephrine from binding to these receptors, and they cause a vasodilatory effect, which it would lead to a decrease in blood pressure. In an emergency treatment, once you're in the hospital, we tend to treat high blood pressure mostly with a few medications in an emergency type of situation. Labetalol is a great one because labetalol, as the law indicates, is a beta blocker, but it's also a alpha blocker. So beta blocker, so we can see that it blocks the heart rate. It actually blocks contractility, and once it blocks the alpha effect, it also causes vasodilation. So as you can see, there's three very strong points that can actually lead to a patient who has a very high blood pressure into very rapidly plummeting their blood pressure, because this medication is able to block a lot of the compensatory mechanism that the heart uses to balance things out. So we gotta make sure that they're always on a cardiac monitor. Okay, we wanna make sure that we constantly monitor their heart rate, their O2 sat. We have to make sure we constantly monitor their telemetry and clinically, because there's no point of looking at your monitors and all those beautiful numbers if your patient's not doing well. The other medication that we use in emergency treatment is called nitroprusside and or sodium nitroprusside. So this medication is a nitrous oxide. So what it does is, once it gets absorbed by the body, get metabolized, and then they produce nitrous oxide. So nitrous oxide, the medication that they like a nitro spray that patients use when they have chest pain, what it does is actually causes diffuse vasodilation, because nitrous oxide, it works in the endothelial of the arteries and causes the endothelial and the intima, the tunica intimas and the media, so the layers in the arteries, to actually dilate. So once you dilate, we have an increased diameter. And remember from earlier in the lecture or in the guide, we actually mentioned that once the diameter is bigger because of vasodilation, then the pressure is lower because the heart doesn't need to push as hard, to get the blood to where it needs to be. Some of the other factors that affect high blood pressure, race or ethnicity. Usually patients of African descent, they tend to have a higher incidence of high blood pressure. There is some research that suggests it could be because of how the sodium or how the salt is actually, how the salt in people of African descent, they are not able to excrete it as fast as other people. But that's just one of the studies. Diet and also diabetes. So diabetes is a big one. Obviously, a lot of times, a bad diet over time plus bad habits, will lead to having a higher risk of developing diabetes. And once people do have diabetes, they tend to become hypertensive. And diabetes does lead to a high blood pressure by many different ways, because makes the blood thicker, right? And also, if you start thinking about it, if your blood has too much sugar in it, And we're gonna picture this analogy of, when you spill, for example, honey or something sweet on the table, and when you try to clean it, there is that much more friction and resistance to it. So if you start thinking about it, if the endothelia of the arteries are coated with some sugar because patient is diabetic, then every time the blood, every time the heart that pumps blood and the blood rushes through the arteries, there is that friction generated that prevents the blood. It's like a resistance, right? So that means the heart needs to pump a little bit harder to overcome that extra stickiness. Physical activity, patients who are obese or have a higher than normal BMI for a prolonged period of time, they are at increased rate for heart problems, diabetes, osteoporosis, a lot of comorbidities that will actually put them in risk for developing high blood pressure. Stress is, unfortunately, in the society that we live in today, stress is something that a lot of people would take for granted almost every day. And we have to understand that, as healthcare professionals, it's very easy for us to tell you have to decrease your level of stress, but it might not be as easy as it sounds, because from suggesting to doing, there's a very wide gap in between. So the best thing is always to try to find out why the patient is undergoing certain stress, because it could be many things. The most important thing is we have to approach this in a holistic way and unbiased, right? So we cannot impose our own views as to why the patient is feeling stressed out, or because you are not doing this, because you're not doing that, right? Our job as healthcare professionals and as nurses is not to judge, but to listen and support our patient. Once we do find out the source of the stress, then we are able to provide them with referrals to specialty services, support groups that they might be able to help them better. So that's it for the hypertension video. I hope it's a very quick guide. It's mostly geared towards nursing students, just to give them just a quick glimpse at high blood pressure. Hopefully that you find this video interesting and also helpful. If you did like it, just give it a like and subscribe. And I'll see you next time in another videos. We'll try to put more videos that will help nursing students in their practice and stuff. So thanks for watching. Bye bye.